Hey guys, I've got it recording here. So let me pull up my chat box again. All right, I've just about got everybody done. Full roll. 28. All right. All right, guys. So what we did last time was kind of look at our antibiotics and try to determine which antibiotic would we choose for a particular issue. All right. So our first issue, if I can get my other one up, it's this young child. Age 40 comes into your office presenting with symptoms of an ear infection. His mother tells you he's allergic to penicillin. He has a narrow esophagus due to a birth defect. A culture is grown to determine what type of bacteria the child has contracted, and the results are as follows. So you have a gram-positive, back that out, gram-positive Streptococcus pneumoniae, and using the chart provided, which antibiotic would be best. Everybody just enter in the one you think would be the best one to use in this case. And there may be more than one answer. And I'll explain that in a minute. So if you've got an answer to that, all right, that's a good one. All right, we got several others on here. Jonathan, is that spelled wrong or I don't recognize that name off the top of my head. All right, we got methicillin. So let's look at a couple of these that have been put out there. So we know based on him being allergic to penicillin, we can just wipe out all the penicillins right then and there. All right. So since methicillin is based on penicillin, we may or may not be able to use it. Now, a few of these may be used in people that are allergic because the molecule has changed enough where they can tolerate it. But according to what we have here, we need to just assume that since he's allergic to penicillin, we're not going to use any of the penicillin-based compounds. That doesn't mean if you look this up on Google, you might find that you can, because there probably are a couple of these that are usable. So let's skip over the penicillins and we can start looking at the other ones. So cephalosporin, not cephalosporin, erythromycin was the first one. All right. And she is definitely correct on that. It's used for patients that are allergic to penicillin. It's good against gram-positive bacteria. That would be a good choice. All right. Let's look at the other ones. Let's see. Jonathan, this one says activity similar to penicillin. We probably could use this one. It's a possibility because more than likely it's similar to penicillin, but it's not similar enough to be allergic. So that would definitely be one that you could probably choose from. Methicillin, again, that's in the penicillin family, so we would use that one. Or vancomycin, let's see, vancomycin is typically used for MRSA only. Luciana, that's one of those. If you remember the antibiotic ladder video, that was one of the ones we kind of limited on that. Now, what I'm going to do on your test is I'm going to give you choices, and there's only going to be one of those choices that's possible. So I'm not going to put, two different ones that are going to be, good to use. Only one of them on the choices will be good to use. But you need to kind of go through like you do with your dichotomous key, and that's really what you're doing. And that's one reason I teach you that dichotomous key and get you to make that, is to get you thinking in that way. And that's really what you're doing here. And you probably did the same thing. You're like, okay, can't use penicillin because he's allergic. So that would be one of my first questions. Is he allergic to penicillin? Yes or no? And you say, well, yes. So we skip over the penicillins and we go to the ones that someone that's allergic can take. Then we could say, is it gram positive, gram negative? That would probably be the first one you would actually do even before the penicillin. So rule out half of them. Some of these are good for gram negative, some gram positive. So it's just like doing your dichotomous key where you're making these choices, all right? And getting your mind to think that way is what this is all about and why we do this, all right? Because you have to make choices, especially in the medical field, that involve people's lives, and you need to be very meticulous about it and do the right thing. if you give someone the wrong medication, it could kill them, right? So you need to be careful and go through the thinking process to make sure you're making the right move there. All right. So let's go to another one. All right. So this one, a new strain of Staphylococcus has been discovered that produces penicillinase. All right. Man tests positive for this new strain and is complaining of skin wounds that won't heal. It is further tested and found to be MRSA. Man's diabetic with a history of wounds that are hard to heal, so this is not unusual. What course of antibiotic would be the best selection for a man in this condition, given that methicillin is not an option? All right. So we've got a methicillin resistant. So if you look through your vancomycin would be a definite good choice, right? Vancomycin, and I just mentioned that earlier. I shouldn't have done that. Anyway, I'm glad y'all picked up on that. I accidentally let the cat out of the bag on that one. But yes, vancomycin is the one you turn to for MRSA. So that's the one you kind of go directly to. It's really good at treating MRSA, but that's not the only one. All right. So let's look, and let me switch over again. So there's some others on here. If you look, like tegacycline or Tegasil, it says it's useful against MRSA, and there may be a reason to use this one, but why would I stay away from this? What's the bad thing about this one? Even though it's good against MRSA, what would make me turn away from it and go to vancomycin? Anybody know? Really, two things. Diabetes probably wouldn't play a big role, but it might. And the reason it might is because look at this, it's bacteriostatic. What does that mean? That means it just hinders the growth of bacteria, and you rely kind of on the immune system to take it out. Well, if he's already compromised by diabetes, that might not be a good choice. All right. Could be hard on the kidneys. Excellent pickup. Diabetic patients have kidney issues, and you might want to really look at that and see. Now, that's not one of the things on our list, but just in your knowledge of diabetes, you would want to pick one that is tolerated by someone with that condition. The other thing is it's broad spectrum. What's that going to do? What else is that going to wipe out? It's going to attack everything. It's going to kill all the good bacteria. And you may make the bad bacteria actually worse by doing that, especially with a diabetic patient that has wounds that are really hard to heal to begin with. So that one is one I would probably take off the table. Even though it says useful against MRSA, there's too many bad things that go along with it, and that's something to think about. I'm going to go back to the first one with erythromycin. That was a good choice for that one, all right? But what if I had to put in here that this is given orally only? Would that alter your decision about that with that young kid? Let me go back and bring that up. There's something about him that if you had to take this orally, that it might be a problem. Yes, throat's narrow. He might choke, all right? Now, if it's a liquid, we might be okay. And you could look at it that way. Okay, he could tolerate a liquid pretty well, but if it's a pill only, we might want to go with something we can either inject or, as Amanda said, a liquid, so that we could get. So there's many factors that play in here, and it's not specific for one bacteria. It's not like, okay, he's got this, I'm just going to give him this antibiotic. We've got to take all these other things into consideration as well. How old are they? Some of these can cause the teeth to darken and brown when you're a young kid, right? And Brittany, you wouldn't know how that was on the kidneys, but we know diabetics have kidney problems. That's why Jonathan brought that up. It didn't say it in here, so you wouldn't know it. So that wouldn't be something you would use to choose. But if it were, that one of these, it says it's rough on the kidneys, that was one of the side effects, then you would definitely stay away from it because he is diabetic, right? Sometimes I'll throw things in like diabetes just to throw it in there to make you think, right? It may have nothing to do with anything. Look at the first one. I threw in that he had a narrow esophagus, but in reality, it really didn't matter as far as what we picked because that wasn't on our list. But if it was, then that would be something to deal with. So let's look at the last one down here. Prisoners come down with a severe respiratory infection. Several other prisoners in the pod have also come down with similar symptoms. Man's coughing up blood, wheezing, has a rattling cough, and complaining of chest pain. Sputum sample has been sent to the office, prison. Serenity, that is a good idea. All right, I just caught that. Yes, and they do that for a lot of patients. They'll actually open the pills and make the powder into a liquid, and they can take it that way. So that would be an alternative. Um, but if there was one that was better tolerated, we'd go to it. All right. Again, it's a thinking process. We're just trying to get, you know, you thinking about all the different scenarios and what's going on. So with the prisoner, the last one, we sent off to the lab at the prison hospital. It's slow to return the results, so we don't know what he has. So what would we go to until you get the results? All right. So what would you think you would give to this person? Now, if you're a thinking person, you can kind of read into these symptoms and what's going on here and figure out what they probably have, but you can't diagnose something without evidence. All right. This is some evidence. We can get this anecdotal stuff, but until you actually know what the bacteria is, you really don't want to treat it. So what would we go with here until we get those lab results back? All right, amoxicillin is a guess. Let me see where amoxicillin that was. Yes, Jonathan, definitely broad spectrum, and that's what I was getting at. You'd want to hit them with everything, all right? And that's what you have to do when you have patients like that, all right? So any of these that are broad spectrum would be good because we don't know if it's gram positive or gram negative. Like this one here, very broad spectrum, that would be a good one to choose from, right? And we don't know much else about it from the information here, but we do know it's broad spectrum. So that would be one that you could choose from. Here's another one and another one. Actually, that got repeated for some reason, and I got to change that next time. It's actually listed here in another place. But these two are very broad spectrum. So again, these are modified ampicillin. Somebody said ampicillin, didn't they? Thought I saw it. Amoxicillin. Okay. This is effective against gram positive and gram negative. Problem with this one though, it's not resistant to penicillinase. So it's one that if it's a bacteria that produces penicillinase, we may get in trouble with it because it will not do any good. It basically makes the amoxicillin, negated. They can't work because that penicillinase is going to break down that molecule. All right. So we'd want to pick one that was out of maybe the penicillin group just based on that because we don't know what they have. All right. So some of these really broad spectrum that kind of kills everything would be where we'd want to go. And then the last thing on here, if you got results and it came back and it was tuberculosis, which is what I would think it was to begin with, it's spreading around this jail, coughing up blood, all the symptoms hit definitely on tuberculosis. Which one would you go to then? You take them off the broad spectrum and then you would go to something else. So which one, anybody pick one out that you could go to for TB? All right. So these are anti-mycobacteria. Remember, mycobacteria is tuberculosis, right? Remember, it has the mycolic acid in the cell wall. So this one says it's very effective against mycobacterium tuberculosis, which is what we have here. So this would be really the only one that we would go to in this case. Not many of these are going to fight off these mycolic acid containing bacteria very well. So tuberculosis treatments is it's a long drawn out treatment. Really hard to get rid of, right? And this is really the only one that we can give that's even effective, right? So this would be one that you would choose for that. And you probably would think about that to begin with. So what I would probably do in this case is who said Jonathan, yeah, broad spectrum. I would give them both a broad spectrum. And since I had a really good idea that this is probably tuberculosis, I would go ahead and start them on this one. As soon as I find out the lab results, I pull back off the broad spectrum and leave it at this one. You always want to go down the lowest point that you can go and pick from. Now, again, when you have this on your test, yes, Luciana, that's the one. So on your test, again, you'll have one of these that will pretty much be a dead giveaway, and the rest of them will be ruled out for some reason or another. Now, I'll try to be a little sneaky with them, but not too bad. I may have one little thing in there that makes a difference, like the narrow esophagus type thing. That might make you go one way or the other. All right. So that's how this antibiotic ladder works. They're only, it may be 4 or 5 questions like this on your test. All right. Now, I want to go over a couple of things, but first, I've got a short video that goes over the classes of antibiotics and explains how they work again, because you'll see that on your test. And by the way, I looked at your test today and I was going to open it up, and I went through the first about 15 questions, and then I started getting into stuff we haven't covered that's in a different chapter. And I don't know how it got in there, but tomorrow I don't have classes all day, so I'll get that test reconfigured, and I'll get you a study guide out for it. That did I put a study guide up for this already? Let me check on something. I guess that's a resounding no, probably. I can't see right now. I'm looking at something else. Oh, yes. Okay. Go buy that study guide. It's made for the test that I want to give. I just couldn't find it on my flash drive. I've got the copy of the test that comes from. I've just got to go and reconfigure it in Blackboard so that it doesn't pull in. It was pulling in questions about metabolism and genetics and stuff that we don't cover until way at the end of the semester. So I don't know how that got in there and how it got mixed up. I think what it was, I had 2 question pools in Blackboard. I accidentally pulled out of the wrong one, or I misnamed one or something, but I'm glad I looked through it and didn't throw it out there for you. But it'll be up by tomorrow, and I'll give you an extra day or two. In fact, I was going to make it due on Thursday, but I'll probably change it, just make it Sunday, right, and give you over the weekend. That'll give you some extra time to study for it. So let me go over this video and close out of these. And I think that, let me make sure it's on my other flash drive. Give me 1 second. But this will just cover some of the stuff we went over the other day about how the different antibiotics work, and just give you a little review for that. So you'll need to know this stuff for your test. So if you want to watch this again, it'll be recorded. Oh man, do that. All right. So, yeah, we've already went over most of this, but oops, wrong place. Oh, somehow it didn't get saved in here. Let me pull it off of YouTube. The video didn't get embedded. It was supposed to be right in here. Make sure it's not down at the end, just in case. No, I'll pull this down. I'll pull it off YouTube. I know where it's at.
It happened.
Sorry, you're gonna have to deal with commercials tonight, but didn't have time to embed it. So let me cut my sound off so
We got the house! 2,000.
Nearly each one of you has taken antibiotics in your life at least once. But what are antibiotics? How do they work? And what is antibiotic resistance? These questions will all be answered in this video. The target of this medication are microorganisms, more precisely bacteria. Once treated with the correct antibiotics, the bacterial infection is eliminated. In general, antibiotics do not function against viruses or fungi. Instead, they are specifically directed against bacteria. The first antibiotic was discovered by Sir Alexander Fleming in 1928. He observed a spot in his petri dish where bacteria did not grow around fungi. These fungi produced an antibacterial substance which killed the surrounding microbes. It is commonly known under the term penicillin, which would later save millions of lives. This discovery is often described as one of the greatest victories ever achieved over disease. How do antibiotics work? There are multiple types of antibiotics and also different mechanisms of action. Some antibiotics disrupt the cell membrane integrity. Others interfere with essential metabolic pathways or inhibit nucleic acid synthesis. Again, others inhibit protein or cell wall synthesis. Altogether, they have one in common. They target essential processes in the cell and prevent bacteria from spreading, either through killing them directly or inhibiting their growth. This video will demonstrate some of these mechanisms of action. One class of antibiotics inhibits the cell wall synthesis. The bacterium has a cell membrane and also a cell wall, which consists of peptidoglycan. These are sugar molecules interlinked with peptide bonds. More closely, a bacterial cell wall looks like this. Without the essential peptide bonds, the cell wall becomes extremely unstable. As a consequence, the cell can even burst due to the high osmotic pressure inside. But how is the cell wall synthesized? An enzyme called transpeptidase catalyzes the reaction necessary to cross-link peptidoglycan. This mechanism is the target of an antibiotic that we already know, penicillin. Penicillin belongs to the group of beta-lactams, and what they do is they inhibit the activity of the transpeptidase. No transpeptidase activity means no cell wall synthesis. The cell wall becomes unstable and bacteria are eliminated. Therefore, most antibiotics of the beta-lactam family are considered bactericidal. Since mammalian cells do not have any peptidoglycan, these antibiotics do not interfere with human cells. Other antibiotics can inhibit the protein synthesis. The bacterial mRNA needs to be translated into protein. Ribosomes are the responsible catalytic machinery of translation. They synthesize a polypeptide chain which will fold into protein. When we take a closer look at the bacterial ribosome, it consists of two subunits, the larger 50S and the small 30S subunit. Tetracycline is an antibiotic that interferes with the small 30S subunit. tRNAs can no longer bind to the ribosome and protein synthesis is inhibited. This does not directly kill the bacterium. However, it depletes them of protein required for growth. This mechanism is therefore considered bacteriostatic. How can this antibiotic specifically inhibit the translation of bacteria but does not interfere with our own protein synthesis program? Mammals, including humans, have different ribosomal subunits, a 60S and a 40S subunit. Upon medication, we can translate our mRNA without any problem. Some antibiotics target one step before translation. These subtypes can inhibit nucleic acid synthesis. The bacterial DNA is usually transcribed by an enzyme called RNA polymerase. It synthesizes mRNA in a process called transcription. An antibiotic called rifamycin can inhibit the enzyme activity of RNA polymerase. This will stop mRNA synthesis and with this indirectly also protein production. Rifamycin does not inhibit the mammalian RNA polymerase. Upon medication, nucleic acid synthesis is not affected in human cells. The use of antibiotics, such as penicillin, first became available during World War II. Numerous soldiers came into hospitals with infections after battle wounds, and the death rate was significantly reduced due to antibiotics. Antibiotics were therefore called wonder drugs. In summary, one can say that antibiotics revolutionized medicine. However, today they are heavily overused, not only for humans. They are also administered to livestock, keeping the animals healthy and routinely prevent disease. Overusing antibiotics promotes antibiotic resistance. Antibiotic resistance is generally caused by simple mutations in the bacterial DNA. Mutations occur almost all the time in all organisms. But when an antibiotic is used and one microbe developed a resistance towards this drug caused by a random mutation, this drug becomes ineffective. Then other antibiotics have to be taken into consideration. They might work, but again, the high selection pressure on the microbes might promote mutations which could lead to multiple drug resistance. In the worst case, no antibiotic would be effective anymore, and the result would be a supergerm, which might cause the next big pandemic. Multi-resistant microbes are already among us. To not draw a future too dark, let me tell you, science is permanently working on the problem by developing new antibiotics. However, we need to be more responsible with the use of antibiotics in the future. Thanks for watching. If this video was interesting and you could learn some new things, you might like this video. And if you want to see more scientific videos, check out the channel and also make sure to subscribe.
All right, so that just gives a good overview of antibiotics and how they work, and also how antibiotic resistance occurs. All right. I want to do a couple of things now while we have a few minutes. So let me go away. Did not mean to do that. Quit. For some reason my screen's locked over here for a second. Give me 1 second. Let me see if I can pull this up. All right, I'm going to pull a test question up that is going to be like some of the others. I just want you to see this graph and understand how to read it, because you're going to see several like this. Now, this one won't be on your test. I'm going to pull this off the old one. Find one. Actually, it's not in that one. All right, why can't I find this now? Here we go. All right, so I just want to show you this. Again, your test is not going to have this particular question, but you'll see some that look a lot like it. So I want to make sure you understand how this works. Hopefully you can read that. Glasses, I can't on your screen, but I can read on mine. So let me see if it'll pull up better this way. All right, so in figure 6.1, which best illustrates the growth of an obligate anaerobe incubated aerobically? All right, so which one of those lines, A, B, or C? So if I put a obligate anaerobe, right, in an anaerobic environment, which one of those lines is going to represent their growth curve? All right, the key says A, A, A. Anybody else want to guess? All right, Sandra says C. Luciana says C. So we got 3 A's and 2 C's. All right, C is actually correct. Think about it. You are putting an obligate anaerobe, which has to live without oxygen. They're obligated to live without oxygen. And if I put them in an oxygen environment, aerobic, what's going to happen to them? They're not going to grow. And they're just going to stay where they're at. They're just going to die. They're not going to grow at all. So that's this level line. So this is the log number of cells. So basically we start out with one cell and we just never grow. All right. So that's what this represents. You heard it wrong? Okay. So again, we have an obligate anaerobe incubated aerobically. So it's in a toxic environment. A facultative, okay. Now facultative, let's change that question. So if it was a facultative anaerobe and we incubated it aerobically, which one of those lines would you pick? B. Exactly. It's not going to grow at its optimum level, right? Because it's in an environment it really doesn't want to be in, but it can tolerate, right? So it's going to grow some, but it's not going to grow wildly like it would if it was in anaerobic conditions, because that's what it prefers, right? So I just wanted to show you one of these graphs so it wouldn't shock you when you saw them, so you kind of understand how they work. So if I have no cells increasing over time, that means I'm dead. I'm not doing anything, all right? If I have a small amount of growth over time, then that means I'm in conditions that's not favorable for me, but I'm not going to die off, all right? I'm just going to kind of trudge along and do my best to keep up with it. So again, a facultative anaerobe really wants to be in an anaerobic environment, but if it's in an aerobic environment, it'll still live. It tolerates it. It's just not its maximum potential, right? So that would be B. So if we're A, that means we're in an environment that we love, all right? So if I asked you, if I put an obligate aerobe and then incubated it aerobically, which one would you pick? An obligate aerobe in an aerobic environment. A, all right? So A would be the correct answer because it's in the environment it wants to be in. It's going to be happy. If it's got plenty of nutrient, it's going to shoot up and grow. So I wanted to go over that with you because I've had students in the past get confused with that. Sometimes these graphs a little difficult to read until you understand what it's actually showing. All right. So again, I just wanted to point that out to you so that you could see kind of how these work with that. All right. Now I've got a couple of little notes at the end. It's only like 4 or 5 slides to finish up everything. So we'll probably get done a little bit early tonight. And then I'll get your test set up tomorrow and I'll send out a message when it's ready. And again, I'll give you a little extension on it since we're starting a little late. I intended it to open today and be fine. I'm glad I looked at it because it would confuse you because there's stuff in there that we have absolutely not talked about. So let me pull that other slideshow up and get that. So let me pull this back over to my other side. And hopefully I didn't close that new. All right. All right, so I think we left off at misuse of antibiotics, and this was covered again in the video a minute ago, so it's kind of a repeat, but I'll go back over it again. So again, don't use outdated, weakened antibiotics. If they're old, throw them out, all right? And don't flush them down the toilet. Don't do that with any medication. Where does that go when you flush medication down the toilet? All right, if you have a septic tank, it's probably not too bad. But if you're on the sewer, it's in the water supply. I can go down to the Chattahoochee River right now and test that water. There's birth control pills, hormones in that water. There's antidepressants in that water, everything under the sun. And a lot of it comes from our sewage because let's say you're a female and you're on birth control. Well, you're urinating out those hormones and they go into the water. And when it goes through the treatment center, they don't treat it for that. It goes right into the river. We're seeing all kinds of strange things happening with fish and other aquatic organisms where they're changing sex and all kinds of weird things because of the stuff that's in there. So if you do have medication, they usually have at least once or twice a year where you can take all your medications in and dump it. And that way they go and incinerate it and get rid of it so that it doesn't. So again, if you have outdated or weakened antibiotics, don't flush them down the toilet, but save them and take them for disposal somewhere. Again, don't use them for viruses or any other inappropriate condition. The animal feed is the big one. We overuse antibiotics there. And then again, people quit taking their antibiotics once they're, feeling better and they don't complete the regimen. And again, you're letting those bacteria that have those mutations that allow them to survive to move on and reproduce and form those superbugs. And we're starting to see these, gonorrhea, syphilis, even these STDs now are getting very, very hard to treat. Where in the past we could just give you an antibiotic and clear them right up. And again, we're seeing that with other like TB and stuff too, is getting more resistant. Leftover prescription, again, you may be taking the absolute wrong antibiotic. Look at those scenarios we went over earlier today. There may be antibiotics that are toxic to you that you don't know about, right? You may have a condition or you may be taking medications they interact with. You don't know what that does. So you don't need to take it unless it's prescribed to you, right? I know we went over this Tuesday, or Tuesday, today is Tuesday, last week, but I just wanted to reiterate that again, right? Right, so antibiotic safety, this is what we do. It's a risk versus benefit. And that's what we did with those little problems we did earlier, right? We look to see the risk versus benefit. If the kid is, allergic to penicillin, we don't want to use it because the benefit's not going to outweigh him dying, right? So again, we need to look at that. Reactions of antibiotics with other drugs. Antibiotics are fairly safe, but there are certain drugs that they should not be taken with. Damage to organs. Some antibiotics, are not good to the liver or good for the kidney, as Jonathan mentioned earlier. So again, we need to look at that as well. If you already have a compromised organ, like with a diabetic patient, their kidneys usually are compromised. We would not want to use an antibiotic that's going to enhance that, right? And then pregnant women are really difficult to deal with because now you have another human being, a fetus, that we're having to deal with and not want to interact with. So again, you have to take all conditions into account and see that risk versus benefit. Are we going to help this person or harm them by giving them this medication? The old credo that doctors go by is do no harm. So you want to do as little harm as possible and get the best benefit out of that. Now, there's some combinations of drugs that are good and others that are bad. We can get a synergistic effect. If you remember the antibiotic ladder video, he's talking about Pip/Tazo, where he's putting two things together. So the effect of two drugs together is greater than the effect of either alone, and they actually work better together than they do by themselves, right? Antagonism is where the two drugs together lessen the effect of either, so they kind of counteract each other. So you wouldn't want to do something that's going to reduce the the viability of that antibiotic. And if they're on another drug and that antibiotic interacts with it, it may be a problem, right? So again, we need to look and see what the patient's taking. And today, doctors, they have their little handheld computers and they just plug in and see what the patient's on, and the computer spits it out for them. They don't have to remember all this stuff, but in the past they did. And they would have to look at charts and say, okay, they're taking this. I can't give them that. I need to give them this. But today, we have computers doing this. And in the future, AI is taking over everything. And it's going to probably spit out the diagnosis and what to give them and everything based on the knowledge that we put into the system. So that's kind of the future where we're going with some of these drug interactions, right? So this is an example of synergism between two different antibiotics. So notice we have a disc with amoxicillin and clavonic acid. That's going to have a zone of inhibition in this dashed circle. And then here we have azithromycin, and that is going to have a little bit larger circle. But if we put them together, we get this huge area of inhibition. So that means they work better together than they work by themselves, right? So they're going to combine to be a lot more effective, right? So that's an example of synergism. Right, so the future of chemotherapeutic agents, we're coming up with new drugs all the time. And there's some new things on the horizon that we can look at and maybe get better at treating patients without the side effects, all right? So virulence factors, what about that particular bacteria makes it so virulent or cause disease or so hard to treat? If we can figure out that virulence factor and dismantle it, then the bacteria then can be hit with another antibiotic, and then that can get rid of it more easily. Sequestering iron, when we have a fever, that's what we naturally do. We sequester iron from the blood and zinc, and those things are necessary for bacterial reproduction. So if we can sequester the iron out of the blood temporarily, then the bacteria can't reproduce. And it's a new way we can go in and prevent bacterial growth. And then other antimicrobial peptides produced by various organisms, right? So these are proteins that certain organisms produce that can have a antimicrobial effect. Phage therapy is the one that I think is going to be the big one, because this is specific. And what a phage is, a bacteriophage is a virus that attacks a particular bacteria. The good thing about it is if we give you that bacteriophage, which is a virus, it will only attach to that particular strain of bacteria, and it's specific for it. So we can go hit that bacteria, not touch any other bacteria in the system, not touch any human cell, and have that magic bullet that goes right in there and destroys that bacteria. And we can genetically alter these bacteriophages where they will have a lethal gene that will be inserted into the bacteria, and then that bacteria will basically kill itself. All right. And again, it can't go and attack anything else. It's specific. It only has a receptor for that particular phage. So that bacteria is the only one that's going to be affected. So we don't have to worry about it getting out and doing anything else to other organisms. It's specific for that one. And then bacteriocins, or antimicrobial peptides produced by other bacteria. And again, this is very similar to the definition of an antibiotic. So there's a lot of new things on the horizon, and hopefully some of these will come to pass, and we can better treat patients without side effects. And that's the main thing we want to get to. All right. All right, so that's pretty much it. That ends our chapter 20. So again, go back and study the bacterial growth, the control of bacterial growth, and then chapter 20, the antibiotics. Most of chapter 20, you can not focus on where it's describing each individual antibiotic. I'm not going to ask you, what type of antibiotic. I mean, yes, I may ask you what type, like, is it a cell wall inhibitor? Is it a nucleic acid inhibitor? I do want you to know that, but you don't have to know each individual antibiotic and what it does and what it treats or any of that. Again, you'll be able to use that sheet that I gave you that has all those antibiotics on it, and you can pull that information from there. All right. So don't concentrate on that. Concentrate on the other two ends, the first part of chapter 20 and the last part of chapter 20, right? And what was in the video today. All right. And then go back chapters, was it 6 and 8, the other two, I think, or 6 and 7. I can't remember. All my chapters run together. I got so many classes, but anyway, it's listed in the syllabus. You know which one it is. So anyways, anybody got any questions about anything? Again, if you're coming in late, I moved the test out. It won't be due until Sunday. I think Amber, come in late. I think so. Amber, if you did come in, go ahead and type here so I can get you on the roll sheet. Thought I popped in here. Mary, you popped in too. All right, guys. Well, if you have any questions, let me know. I'll be here for another few minutes. If not, you can take on off. And I'm going to finish getting rolled, make sure I got everybody on there. Okay, Amber, I got you. Sandra, I got you. We'll turn the light on so I can see. All right. Yes, Lisa, I'm sorry. I totally forgot, and I'll post this one as well. I totally forgot to do that. You're welcome. It takes so long for these videos to process that I forget to do it because it's 30, 40 minutes later and I get tied up in something else.